Hello, and welcome to this RPTH Research Recap, where we dive a little deeper into the science being published at RPTH. My name is Dr. Mandy Lau. I'm an internist hematologist at the Erasmus University Medical Center in Rotterdam, the Netherlands, with a special focus on thrombosis and hemostasis. I'm also a member of the editorial board of RPTH. I'm very pleased to introduce Dr. Rick Ikesaka. Dr. Ikesaka is an assistant professor at Master University in Hamilton, Canada. He completed his residency training in hematology and fellowship in adult thrombosis medicine, as well as a master's in science in epidemiology at the University of Ottawa. He's the current chair of the Convector Research Network's Clinician Investigators Group. His research interests are in the areas of upper extremity DVT and anticoagulation in bariatric surgery populations. He recently published a paper in RPTH regarding thromboprophylaxis with rivaroxaban in patients with malignancy and central venous lines, the Trimline pilot randomized controlled trial, executed on behalf of the Convector Network. Dr. Ikesaka, we look forward to hearing your presentation.
So thank you for inviting me here to present on this recent RPTH publication. It's my pleasure to present on the research on thromboprophylaxis with rivaroxaban in patients with malignancy and central venous lines, the Trimline trial, which is a 2-center open-label pilot randomized controlled trial. Just to recap, we are going to be talking about upper extremity venous thrombosis, which represents about 4 to 11% of all DVTs and are associated with a different set of risk factors, including cancer, central venous catheters, and thoracic outlet syndrome. These types of clots are much less studied and are generally less likely to present with major pulmonary embolism than the more studied lower extremity thrombosis. However, there has been a need for additional research in this area. More and more patients are developing cancer given our aging population among Western populations. And there is increasing use of central venous catheters to provide supportive care and also administer chemotherapy in cancer populations. In other studies, patients with indwelling central venous catheters and active cancer have been reported to have rates of thrombosis of up to 7%. And there has been evidence that other types of blood thinners, such as low molecular weight heparin, which is a subcutaneous injected anticoagulant, is able to reduce the risk of thrombosis in this population with central lines from 6.8% to 3.7%. Currently, though, routine thromboprophylaxis in cancer patients with central venous catheters is not been recommended by guideline agencies. Recently, there have been 2 studies using low-dose direct oral anticoagulants, the AVERT and Cassini trials, which have demonstrated the efficacy of low-dose oral blood thinner, DOAC, in the primary prevention of thrombosis in high-risk cancer patients. And so since central lines are a major risk factor for thrombosis in cancer, we thus designed the Trimline pilot study to demonstrate the feasibility of a full-scale trial to test the hypothesis that primary prophylaxis with rivaroxaban 10 milligrams daily for a 3-month period would decrease the number of major venous thromboembolic complications over a 3-month period when compared to the current standard of care, which at this time is actually no treatment or observation, as it has not been recommended in this population to provide any anticoagulants when central lines are inserted. This was a pilot feasibility study with a prospective randomized open blinded endpoint design in a population of adults with new or existing cancer and a new central venous catheter that was inserted within the last 72 hours. They were randomized as a 1-to-1 ratio to either rivaroxaban 10 milligrams daily for 90 days or observation, which is the current standard of care. This included 2 centers, the coordinating center, which was the Ottawa Hospital in Ottawa, Canada, and the additional enrolling center, which was the Juravinski Cancer Center in Hamilton, Canada. We had set the primary pilot trial feasibility outcome as the enrollment rate, as we wish to demonstrate the feasibility of performing a full-scale trial with this pilot. We set this at a rate of 8 patients per month enrollment, which was set as the cutoff for determination of trial feasibility. And this was chosen based on the number of potential sites that were interested and could be used for enrollment in the full-scale trial within the Canadian CanVector Research Network. Secondary outcomes also included the proportion of subjects that were eligible and enrolled in the study, the reasons why patients chose to not participate in the study, and the overall adherence to the study drug and loss to follow-up. The clinical outcomes that would be collected for the full-scale trial were also collected for the pilot study. At the end of the study, I will present the, sorry, could you, apologies for that, a little misstep. Could I just go back on that a little bit, if you could cut that? But, I'll now present the results of the Trimline study. This enrolled 105 patients from March 2019 to February 2020. And the primary endpoint was met with a total of 9.5 patients a month being able to be enrolled in the between the two sites in participating. Overall, 35% of those that were eligible enrolled in the study. And the primary reasons why people wished to not enroll in the study was that they were overwhelmed with all of the medical care that was required, including their cancer diagnosis and other care requirements. They were already on an anticoagulant for another reason, or they didn't want additional pills or complication of their therapy. I present the baseline characteristics of the two arms of this study. Overall, the mean age was 61, with slight predominance of women in the trial, with 68.5% of the population being female. A wide variety of cancer types were represented, with an enrichment for breast and colorectal cancers, which were underrepresented in the other studies looking at primary prophylaxis in cancer, such as AVERT and Cassini, as these particular cancers are not represented in the Khorana risk stratification score. Approximately 3/4 of the patients had a PICC line, with the remainder having a portacath. And there was a slight imbalance in the groups in this pilot study for metastatic disease, with 34% in the rivaroxaban arm and 43% in the standard of care. There were complications in 3 patients in the rivaroxaban arm, 2 of which were upper extremity DVTs, and 1 of which was a splanchnic vein thrombosis. In the standard of care observation arm, there were a total of 3 major venous thromboembolic events and 2 other thrombotic events, including a splanchnic vein thrombosis and superficial vein thrombosis, for a total of 5 total thrombotic events. In terms of other related complications, there were markedly fewer catheter-related complications in the rivaroxaban arm, and these were associated with positional occlusions, infections, and CVC migration. Bleeding rates between the 2 arms were approximately similar, with clinically relevant non-major bleeding being approximately 2 in each arm, with no major bleeding events. In conclusion, the Trimline pilot study met its enrollment targets and has suggested that a full-scale definitive randomized control trial on the topic of primary prophylaxis in cancer patients with central venous catheters is feasible. And I have the pleasure to report that the full-scale Trimline study has actually been fully funded by the Canadian Institute for Health Research very recently, and is being prepared for launch in conjunction with the CanVector Research Network.
Thank you, Dr. Ikesaka, for presenting your work. I have a couple of questions for you, if that's possible.
Of course.
In your pilot trial, you've included PICC lines and port or bar ports, but no jugular or subclavian lines or tunnel lines, such as Hickman catheters. Could you please elaborate on this choice, and are you considering to include these in the future full large RCT?
Yes, so we did not actually encounter or enroll these patients in this study. We are hoping to do so for the full scale study. We didn't specifically exclude them for this study, but we did not actually run across any, as they're less common. And based on the types of patients that were receiving therapy at these centers that we're enrolling, the vast majority of the central venous access devices were PICC lines and portacaths. And so, as it was a pilot study and we only enrolled approximately 50 patients per arm, we just happen to not encounter any. But our hope would be to not limit this for the full scale study, and we would enroll all patients with these types of central catheters.
Okay. Yes, it's probably very center related because it's a 2-center study now. But in the Netherlands, for example, we don't really work with PICC lines anymore, but rather with like a more central venous catheters such as Hickman catheters. So that's why I was wondering the choice in your methods. And in your introduction, and also in the introduction of your presentation, you mentioned the Cassini and AVERT trials as a rationale for the choice of rivaroxaban as thromboprophylaxis. However, previous trials such as the REALIGN trial have indicated that DOACs may be inferior to vitamin K antagonist or low molecular weight heparin in patients with mechanical valves, potentially caused by a larger prothrombotic contribution of the contact pathway. There have been some signals or discussions that this could also be applicable to CVL-related venous thrombosis. So I was wondering, did you take this into consideration in your pilot trial and a choice for rivaroxaban? And would it be an option to consider a third arm in the large RCT with low molecular weight heparin? And why did you decide for rivaroxaban over, for example, also other DOACs such as apixaban?
Fair enough. In terms of this, yes, we were aware and did consider that there is evidence that suggests that contact pathway may play a larger role when there is prosthetic material involved, and that was a concern related to the efficacy of this study in general. We were reassured in that there is some cohort data such as the Catheter 2 study that uses direct oral anticoagulants in cancer patients with central venous catheters that has been published. And we also were interested specifically in looking at this medication related to its ease of use, and we would like the full-scale trial will actually answer the question of, or help us answer the question of whether or not this population will have a decreased efficacy of this particular prophylaxis. We do know that that low molecular weight heparin prophylaxis is efficacious in this population and in many other cancer populations for primary prophylaxis, but uptake has been quite poor related to a variety of factors, including the extended duration of therapy and the patient susceptibility of repeated daily injections, as well as funding issues, given that primary prophylaxis is not a funded indication in many jurisdictions, and low molecular weight heparin is quite expensive. So we were hoping that with a oral medication, we would be able to demonstrate a efficacy of another agent that would be more tolerable and more accepted by patients, and hopefully lead to better uptake in a primary prophylaxis setting. In terms of why we selected rivaroxaban and apixaban in this context, it was primarily cost related, related to the budget constraints of the trial itself and the ease of use of a single daily dose medication. Most of the other competitors are all anti-10A inhibitors, and we had no specific data suggesting superiority over one over the other in this context. And so we decided to go with rivaroxaban given its single tablet and thus slightly decreased cost for our study operations. In terms of adding a third arm to our full-scale study, we considered it, but did not proceed to our first round of funding applications with it, mainly because there are estimates of efficacy in both the meta-analysis by D'Ambrosio and other studies looking at central venous catheters and cancer patients. So we felt that risk estimate had been established, and we decided to proceed onwards with just the similar design with the DOAC in central venous catheter patients. Given that we've now been fully funded with the existing design, we're hoping to just press on at this time and carry on.
Fair enough. I mean, it's perhaps worth considering should for a third trial, should this one not show superiority, of course. And as a final question, I was wondering, for your full large RCT, what will be your power considerations? The baseline risk that your pilot trial showed for the observational arm is 9.4% of thrombosis, which is perhaps a little bit higher than described in literature. But what is the expected reduction or relative risk reduction that you are powering your trial on with rivaroxaban?
So we did a power calculation based not on the results of this pilot study, based on the published literature that was in existence in terms of the risk reduction that was for other trials using low molecular heparin or DOACs in upper extremity or catheter-associated populations. When we performed this calculation for 80% power, we came up with a number of approximately 1,900 patients that would be required. We had based this on a lower rate of VTE of a risk estimate of approximately 0.56 to 0.6 based on the literature. And so we conducted our power calculation to at least show a 30% risk reduction in terms of VTE risk in this population.
And maybe another last question, sorry. Are you considering measuring anti-10A levels, or do you consider dose adjustments in case of interactions with, for example, immunotherapy or other drugs such as CYP3A4 or glycoprotein 450 inducer inhibitors to estimate the efficacy of your rivaroxaban?
We did not include that in this particular trial, and I agree that it would provide some very interesting data in terms of making sure that the levels are appropriate in the setting of prophylaxis setting. We chose not to include it in this study mainly due to feasibility constraints. The design of our study excluded any major CYP interacting medications, so patients that were on them were excluded at the start. And the other concern that we had was at this time, there are very few labs in Canada that run anti-10A levels. There's probably maybe 4 of them across the country. In order to obtain anti-10A levels from all of the sites that would have been required in the full-scale trial would have been challenging from a cost and logistics perspective, namely because all of the samples would need to be compiled and shipped to McMaster or to Ottawa, which generally are the centers that will be able to run this assay. So at the time, we decided to go purely with clinical outcomes in this context.
All right. Thank you, Dr. Ikesaka, for presenting your work and giving us some more insight into your article on the Trimline pilot randomized controlled trial. We will look out for the protocol of the upcoming multicenter large RCT. We hope viewers will read the full detail of your paper on our site. And Dr. Ikesaka, I hope you will publish again in RPTH. Thank you for watching and keep an eye out for the next RPTH recap.